So today I will be demonstrating how to do carotid stenting. Carotid stenting is used to prevent second stroke or to prevent first stroke if a patient has having severe carotid stenosis. So if a patient has got more than 50% carotid stenosis in DSA and it's symptomatic, we need to do stenting. Or if a patient has got more than 60% with contralateral occlusion, with other comorbidities, depending on situation, we need to do carotid stenting even to prevent first stroke. So I'll be demonstrating a patient, carotid. He is a 60-year male, hypertensive diabetic, presented with a small TIA, and he has got severe carotid stenosis. So here now we are doing a fluoroscopy and taking the guiding catheter along with the diagnostic catheter. This is called telescopic technique. So once we reach the arch, so we take the diagnostic up, and then sometimes it is difficult to hook the left carotid. In that situation, we use a Sim2 catheter and then take an extend manual. So here I am trying to hook the left carotid. Once it is hooked, we take the wire along with the diagnostic and the guiding over it. So here we are taking, I am taking the wire distally. So because there is stenosis, we take a run using the diagnostic catheter, and we can take the thermo wire into the external carotid artery so that we get a good support, over which we can take the guiding catheter into the left common carotid artery. So here I am pushing the diagnostic up over the wire. The wire is in external carotid artery. And now easily the long sheet will go into the common carotid artery. Okay. Then after this, we take an intracranial shoot to see how is the flow and everything, because we need to compare post-stenting whether there is any distal emboli or not. You can see this is a neck shoot. You can see there is severe carotid stenosis. And usually we do all carotid stenting using a distal protection device. So it will the distal protection device helps us to prevent emboli going inside the brain if they during plasty or post stenting. So here I am crossing the lesion and I am deploying the distal protection device. Usually we deploy it in the straight segment in the distal cervical ICA. So once it is deployed, we take a 4 mm balloon. Some people do direct stenting, but I prefer to do pre-stenting angioplasty. So when we are doing pre-stenting angioplasty, you need to alert the anesthetist that they need to be ready with atropine. And we also should know where is the lesion by doing unsubstructed shoots, and vertebra we need to concentrate. So here we are doing pre-stenting angioplasty. So there was a drop in the heart rate, but that can be reversed with atropine. And then I'm using a stent. So these are all self-expandable stent. In carotid stent, we won't get a drug-eluting stent because the stent size is bigger, the artery size is bigger. The restenosis rate in these territory is very less, so we don't have it coated the stents. So this is after proper positioning, we deploy the stent across the stenosis. If you can also ask the patient to cough if there is a severe bradycardia. So you need to deploy the stent from normal artery to normal artery. So once his stent is deployed, if a patient is young, we can do post deployment of stent angioplasty also. So this is angioplasty. Post angioplasty we take around. and you can view in different views whether it has opened fully. So there is a little bit of neck. So we inflated the balloon again. Mild residual stenosis is okay, less than 30% is okay. We can see that the stent has opened completely. There is no significant residual stenosis. So post-stenting, we have done a shoot, and then we are retrieving the distal protection device. So after the angiogram, you need to take intracranial shoot and the neck shoot to see whether there are any emboli or not. And this is done under local anesthesia. So you can discharge the patient in 1 or 2 days' time. Thank you.